Okay, good morning, everyone. Welcome to today's session. Today, we are going to discuss about Crohn's disease. In the last session, we discussed about ulcerative colitis, one of the inflammatory bowel diseases, which are sort of rare in Bangladesh. But if you go to the GHPD or the gastrointestinal outdoors, or even in the general surgery outdoors, you will now see quite a number of patients who who comes to you with symptoms or complications of ulcerative colitis and Crohn's disease. That's why I think it's a very important topic. And now in the examination, in the exam, final prof, or even in the postgraduate examinations, there will not be any cases regarding these problems. But okay, so let's discuss about Crohn's disease. Now, if you know, another name for Crohn's disease is regional enteritis. That means it involves certain region of the gastrointestinal system, not the whole gastrointestinal system at the same time. Okay, we will come to that in a moment. Now, as we have discussed, Crohn's disease. Now, we have already discussed about ulcerative colitis and Crohn's disease. They have quite similar characteristics. They are chronic. That means they are long-lasting, long time. They will take a long time. Maybe years, maybe 1 year, 2 years, maybe 10 years. They will not go away with a single medication. A long-term medication is necessary. Idiopathic, that is, the causes are unknown. Relapsing, what do you mean by relapsing? What do you mean by remitting? Relapsing means, for example, if you draw a graph of severity of the disease and time, you will see in case of Crohn's disease, the graph is something like this. The severity increases, and sometimes it goes and it disappears. Sometimes again it becomes severe. Sometimes the severity decreases, and sort of like this. Now, this type, when the disease is gone and again the disease comes back, this is called relapsing. And whenever remitting means it fluctuates, it goes down, the severity goes down, again increases. Relapsing means it is cured and again then sometimes later again the disease comes back. Immune, that means the immune system has something to do with it. And inflammatory, you can understand it's a chronic inflammatory disease. So this is sort of a definition of Crohn's disease, which is quite similar if you look at it. Crohn's disease is an idiopathic, that is mean of unknown cause, chronic, transmural. Now this is where the difference comes between ulcerative colitis and Crohn's disease. If you remember, ulcerative colitis is actually a disease of the colonic mucosa only. Mucosa and submucosa is maximum that's involved. But in case of Crohn's disease, all the layers are involved, all the layers. If this is mucosa, then this is submucosa, then the muscle layer, and then the serosa. If this is the thing, in case of ulcerative colitis, only the mucosa is involved. But in case of Crohn's disease, transmural, the whole layer is involved. It's an inflammatory process of the bowel that involves any part of the gastrointestinal system. This is very, very important. If you remember, in case of ulcerative colitis, it's mostly, because it says colitis, that means it involves mostly the colon. But in case of Crohn's disease, it can involve any part from mouth to anus, any part. But it has predilections for certain parts, but from mouth to anus, any part can be involved. In case of Crohn's disease in mouth, you may see aptoid ulcers, small aptoid ulcers, or even perianal disease like fistula may be found. But in case of Crohn's disease, it mostly involves the small bowel, particularly the terminal ileum. Okay, these are some of the statistics. Now, in case of Crohn's disease, it's, as I have discussed in this very at the beginning of our discussion, that it in our country it's not very common, but in the Western countries it's quite common. Males and females are equally affected. There is no statistics that show that it has any predilection to a particular gender. Both male and female patients are found in case of Crohn's disease. Smokers, now this is very important. Remember this. Smokers are 3 times more likely to develop Crohn's disease. Now, if you remember from the lecture we have discussed in ulcerative colitis, that in case of ulcerative colitis, smoking is protective. In case of ulcerative colitis, smoking is protective. In fact, sometimes those patients who are smoking do not have a very severe severe symptoms of ulcerative colitis. But in case of Crohn's disease, if you are a smoker, the diseases will be more severe. And it is very important that it's part of the treatment that if you're a smoker with with a Crohn's disease, you must stop smoking. Crohn's disease. Now, this is again with both ulcerative colitis and Crohn's disease. This happens in the teens and the 20s. That means usually patients are below 40 years. You'll see that most of the patients are below 40 years. Etiology. Now, the first and the most important thing you have to understand, we have already discussed idiopathic. That means we incompletely understand, we don't really understand if there is any genuine reason for this disease. But we think that there are some genetic and there are some environmental factors. For example, genetic means whenever a person has certain inflammatory characteristics to particular agent. For example, if you remember asthma, some patients have dust allergies. Other people don't have. Some people have cold allergies. Similarly, in case of intestine, if you take a particular type of food, or if there is a particular type of foreign body or a particular type of antigen or a particular type of bacteria or virus enters the gastrointestinal system, people who are genetically susceptible, which produce a severe inflammatory reaction. Environmental can be other factors. For example, smoking can be a factor. As we will discuss, smoking increases the risk. Now, pathogenesis is slightly complicated. Now, we are not very, we will not go deep into the pathogenesis, but I will just discuss slightly about it. If you see, if this is, for example, if this is the intestinal wall, and let's say there is a blood vessel going from here. Now, if there are some bacteria that enters the wall, this bacteria is a particular antigen. Now, this particular antigen binds with a immune cell. For example, let's say it's a T cell. Now, this T cell will produce some reaction, usually an immune reaction against this foreign body, right? But sometimes it produces a very severe immune reaction, and which cannot be controlled. If you look at this, it produces some pro-inflammatory cytokines. For example, interleukin-2 and tumor necrosis factors, which produces an uncontrolled inflammation, and which as a result may destroy the wall. As a result, it destroys the wall. So this is pretty much the pathogenesis. You can learn about it. It's not very important. This is same things written over here. Now, what is the pathology? This is very important. Remember, the terminal ileum is the most commonly involved part. In 60% of the patients are involved in and around the terminal ileum. Colon may also be involved. 1/3 of the patient as a colonic involvement. Stomach, duodenum may also be involved. 5% of the patients may have this sort of problems. Perianal regions are very, very common, very, very common. Up to 75% of the people has perianal lesions. You will see, in case of perianal lesion, you will see multiple fistulas in and around the perianal region. If you see multiple fistulas, it means more than 3, 4, 5, 6 fistulae in and around the perianal region. Always think of Crohn's disease as one of the cause. As we have just discussed, that Crohn's disease is a disease of the ileocecal region, shows fibrotic thickening. If you look at this place, in these regions are fibrotic thickened. These regions are thickened with narrowing and fat wrapping. If you look at this area, there should not be any fat over here. The fat is wrapped over here. What I'm trying to say is that if this is the, for example, this is the ileum, and if this is the mesentery, you will see that the mesentery fat is creeping into the ileum, in and around the ileum. This is another result of a chronic inflammatory disease. This is called fat wrapping. This is very, very important. You will see in case of Crohn's disease, whenever you open the patient's abdomen and if you see fat wrapping, something like this, you can immediately understand that the patient is having Crohn's disease. Now, Crohn's disease, and if you look at another features of Crohn's disease is it is has keep lesions. That means a particular part is involved, and you'll see the adjacent parts are not involved. Again, another part from here may be involved. So these are called skip lesions. Skip lesions. Another thing you will see, we will discuss this a bit, that they have ulcers, deep ulcers and deep fissures. And in between there's edematous rectal mucosa. What I'm trying to say is that if these are the mucosal cells, they become edematous. These cells become edematous. But in between the cells, there are deep ulcerations and fissures. Just like this. And these ulcers are usually sort of like this, like a snake. That's why they say serpingeous. That means like snake-like ulcers. The ulcers are sort of like snake. So, and in between the mucosa is inflamed and edematous. They look like cobblestones, just like this. Now, microscopically, this chronic inflammation involves all layers. All layers, very important. But the most important thing is non-caseating giant cell granulomas are present. This is very, very important. Remember this thing. This is the most important feature that is necessary to diagnose Crohn's disease, that non-caseating giant cell granulomas. You know that caseating granulomas are found in case of tuberculosis, right? In case of Crohn's disease, this is non-caseating granuloma. Very important. If you can find non-caseating granuloma, then you can be very sure that this is a case of Crohn's disease. Deep fissuring and ulceration we have just discussed. And there may be normal areas in between. Now, in the last presentation, everyone was asking about what's the difference between ulcerative colitis and Crohn's disease. Yes, this is very, very important. In case of ulcerative colitis and Crohn's disease, what is the difference? Now, as we have already discussed, that in case of Crohn's disease, it can involve anywhere in the gastrointestinal system. But ulcerative colitis mostly involves the rectum and then the colon. As we've just discussed, ulcerative colitis, rectum is always involved. And in case of Crohn's disease, it's often spared. Perianal disease, very common in case of Crohn's disease, but in ulcerative colitis, it's rare. Fistula formation, very common. Stricture, very common in case of Crohn's disease. Why is this very common? As because in case of, sorry for that. In case of stricture, in case of Crohn's disease, if you remember, the patient has a transmural inflammation, right? Transmural inflammation. That means all the layers are involved, all the layers. And chronically, when they're involved, they cause fibrosis. They cause inflammatory fibrosis. And that causes narrowing of the lumen. Or in other words, the stricture, the chronic inflammation causes fibrosis, which causes stricture. Microscopically, full thickness is involved in case of Crohn's disease, and mucosa and submucosa is only involved in case of ulcerative colitis. Granulomas, common. Non-caseating granulomas. Fissuring, common in case of Crohn's disease. Crypt abscess, remember this. This is the only thing. The crypt abscess is the thing that is common in case of ulcerative colitis. So again, what are the difference? Crohn's disease can affect, this is very important, that's why I am telling it again. It can affect any part of the gastrointestinal system. Ulcerative colitis is only a mucosal disease. Crohn's disease is a full thickness. Ulcerative colitis produces confluent disease, that means continuous disease, but Crohn's disease produces skip lesions. Crohn's disease causes stricturing and fistulation, but it's very rare in case of ulceration, ulcerative colitis. Granulomas, common in case of Crohn's disease. Perianal disease, common in case of Crohn's disease. Now, as we have just discussed, Crohn's disease involves the terminal ileum, and it may produce features mimicking appendicitis. Does not occur. In fact, remember, in Crohn's disease, abdominal pain is common, but in case of ulcerative colitis, usually there is no abdominal pain. Resection, surgery is maybe curative in case of ulcerative colitis, but it is not curative in case of Crohn's disease. So we have already discussed that Crohn's disease is common in patients below the age of 40. But sometimes there may be a second peak in and around the age of 70. And flare up and remission, these are always, relapse and remission are very common in both ulcerative colitis and Crohn's disease. Remember this. Presentation. Presentation depends on two things. Number one, pattern of the disease. Number two, site of involvement. For example, pattern of disease, whether it's acute or is it chronic? Site of the disease, whether the mouth is involved, whether the anal canal is involved, whether the perianal region is involved, whether the ileum is involved, it depends. The signs symptoms depends on what site is involved. So in case of acute case, as we have just discussed, it resembles features of appendicitis. That means the patient may have abdominal pain, which is quite common. This pain is usually due to obstruction and stricture. Obstruction and stricture. Perforation, in severe cases, there may be perforation, there may be diffuse peritonitis, there may rarely be fulminant colitis as well. In a chronic case, there may be diarrhea with colic. Again, it's an obstructive feature. Obstructive features may be present. There may be mass in the right iliac fossa. There may be abscess, intra-abdominal abscess, fistula formation, which are also quite common. Now, if you remember, toxic megacolon is common in ulcerative colitis, but it is less common in case of Crohn's disease. Systemically, there may be fever, there may be anemia, there may be weight loss. Especially if young children are affected by Crohn's disease, they will have stunted growth. Perianal region, we have just discussed that the perianal region, they have abscesses, fistula, multiple. There may be multiple fistula. On digital rectal examination, remember this, rectum is usually spared. So usually rectum is normal, but if rectum is involved, it will be thickened, nodular, and irregular. There may be a stricture in the anorectal junction. If the muscles, sphincters, if the sphincters are involved, anal sphincters that is, then there may be incontinence and multiple discharging sinus. If you look at this, multiple discharging sinus may be present, which looks like a water can perineum. Water can, if you remember, water can looks like something like this. So in the can of the water, if this is the thing you're holding, usually water can looks multiple openings are over here. So similarly, the perineum, there will be multiple discharging sinus, which resembles a water can perineum. Now, what are the extraintestinal manifestations? Extraintestinal manifestations, some of these manifestations are related to the disease activity, some are unrelated to disease activity. That means some of these, for example, these will be, the severity of this will be proportional to the severity of the disease. That means if severe disease, there will be more apsoid ulcerations. But these ones are not related to the disease activity. That means doesn't matter how severe the disease is, they will go in their own pace. But these ones will follow the severity of the disease. So there, you don't have to know all of them. You can just, for example, iritis, uveitis, there may be arthropathy, and there may be in skin, erythema nodosum and pyoderma gangrenosum. In the mouth, there may be aptoid ulcerations. Why there is gallstones? Very simple, because the terminal ileum is involved. The terminal ileum is involved. As a result, most of the bile salts are not absorbed. The bile cannot be absorbed. The bile salts cannot be absorbed. Discuss why it looks like a snake. Complications again. Some of the complications: stricture formation, very common. Fistulation, abscess, very common. Rarely there may be a neoplasm. Rarely, it's not very common. Arthritis, common. Uveitis, common. Skin involvements are common. And anastomotic recurrence, this is important. Anastomotic fibrostenosis, additional obstruction. These are very, very important because this shows that surgery is not curative. It means that the surgery is not curative. The surgery will not cure the disease. This is very important. Remember this. So this is mostly a medical disease. This is not a surgical disease. Again, the different types of fistula. The internal fistula, the enteroenteric fistula, enterocolitis fistula, extraintestinal fistula, for example, enterovesical. This is quite common. I have seen almost 4 or 5 patients who has enterovesical fistula. That means the intestine has communicated with the urinary bladder. This is not uncommon. You'll see quite a number of patients with enterovesical fistula. In fact, this is actually one of the more common causes of any types of fistula. I think Crohn's disease is one of the most common causes of any type of enteric fistulas. And there may be external fistula as well, enterocutaneous fistula. So these are different types of fistula that may be present. Interintestinal fistula, that is enteroenteric fistula. Extraintestinal fistula may be present, and enterocutaneous fistula may also be present. Usually, enterocutaneous fistula is more common. Usually, enterocutaneous fistula is more common over here. Crohn's disease. Now, diagnosis, very important. Now, the first and the most important thing you need to know is it does not diagnose with complete certainty. It's very, very important. It's mostly from the signs, symptoms, and some of the features we diagnose. It's very rarely we can be absolutely certain that this is a case of Crohn's disease. As we have discussed, the granulomas are not always present, which are the confirmatory signs of Crohn's disease. So this is very important. It cannot be diagnosed with complete certainty. But a colonoscopy is definitely the number one investigation that should be done in case of Crohn's disease, as because the colon can check the whole, the colonoscopy can check the whole colon and also the terminal ileum. The colonoscope can go check the whole colon and also enter and see the distal 20 centimeters of the terminal ileum. So usually a colonoscopy is very, very helpful. Capsule endoscopy is another very helpful investigation, but it should be done with caution, especially if you think that any obstruction is present. Laboratory investigations, again, definitely there may be anemia. There may be anemia due to blood loss, due to iron deficiency anemia. There may be due to vitamin B12 deficiency, as because the terminal ileum is involved. There may be malnutrition. Acute phase proteins will go up. Endoscopy definitely, colonoscopy definitely is a very good investigation. In colonoscopy, you will get aptoid or aphthous-like ulcers, stricturing, terminal ileum, you'll see ulcerated and strictured. Endoscopy, again, you'll see a few similar features of chronic inflammation. Enteroscopy is another investigation, very helpful. There you again see it's ulceration and stricturing. Capsule enteroscopy. Remember that if you think there is this type of obstruction over here, don't do capsule enteroscopy. Imaging, high resolution ultrasound. Again, you'll see signs of chronic inflammation, thickened loops of bowel. There may be intra-abdominal collections you may find. Small bowel enema, definitely a very important investigation. You will see again stricturing, pre-stenotic dilatations. String signs of Kantor, I'll just show you this. If you look, this is, what is a string sign of Kantor? Now this is the colon. Now this part is the ileum. This is the ileum. But the terminal ileum has been involved and it has narrowed. So this part is called the string sign of Kantor. This part is called the string sign of Kantor because the inflamed part it has chronic inflammation and it's fibrosed and stricture has been forming. As a result, this is a very narrow area, and which shows, in case of enema, it shows like a string. This is called string signs of Kantor. This is what you'll see in case of Crohn's disease, the multiple edematous mucosa, and in between there will be the ulcerations. It's a beautiful CT scan which shows what happens to the terminal ileum. If you look at the terminal ileum, the wall has thickened due to chronic inflammation. Similar features in MRI. Now, MRI is now a preferred investigation because in case of Crohn's disease, you may need to do multiple investigations. So you do not want the patient to expose to radiation of CT scan. In case of ulceration, there is no radiation. In case of MRI, there is no radiation. So MRI is a preferred investigation nowadays. As we have already discussed, that ulcerative colitis is a confluent disease. It starts from here and goes all the way. But in case of Crohn's disease, it involves particular area. Then again, there's no involvement. And then again, there's involvement. These are called skip lesions. We will discuss this. So presentation, I'm just trying to summarize what we have discussed. These are very important at undergrad level. These are the more important features. Acute inflammatory presentations, features similar, features that is similar to acute appendicitis. Why? Because of terminal ileum involvement, there may be abdomen, there may be pain in and around this area, and there may be a confusion whether this is a case of appendicitis or not. Chronic inflammatory presentation, there may be chronic inflammation, fibrosis, and there will be narrowing or stricturing. Scarring and narrowing in case of chronic inflammation of a terminal ileum. There may be enteroenteric fistula formation. There may be enterovesical fistula formation. This is an extraenteric fistula. This is intraenteric fistula. This is extraenteric fistula. There may be a localized phlegmon. There may be a localized abscess formation. There may be a lump. So these are the complications. So complications are abscess formation, stricture which will result in intestinal obstruction. There may be fistula, different types of fistula we have discussed. Perianal disease, rarely there may be a malignancy. Hemorrhage, malabsorption, all these are very common. Crohn's disease and ulcerative colitis, we have discussed many times about the differences, but at undergrad level, that is the most important thing that should be discussed. Again, I will discuss slightly, if you remember, Crohn's disease. In case of Crohn's disease, the terminal ileum is involved. Colon is more involved in case of ulcerative colitis. Rectal involvement is more common in case of ulcerative colitis. Anal involvement is more common in case of Crohn's disease. Bile duct involvement, it is more common in ulcerative colitis. Sometimes Crohn's disease, there may also be some involvement. Distribution, patchy, that means skip lesions. In case of ulcerative colitis, continuous, endoscopy. There will be snake-like ulcers in case of Crohn's disease, and with continuous ulcers in ulcerative colitis. Depth, shallow in case of ulcerative colitis, deep in case of Crohn's disease. Fistula, common in case of Crohn's disease, rare in case of ulcerative colitis. Both are autoimmune disease. These are not very important, but granuloma, yes. In Crohn's disease, there may be granulomas. In ulcerative colitis, no granuloma seen. Surgical care, very, very, very important, this one. Ulcerative colitis cured by removal of the colon. And in Crohn's disease, it is not cured by surgery. Smoking, lower risk. Crohn's disease is higher risk. Remember this, the difference is if you understand the difference, it's very easy to understand ulcerative colitis and Crohn's disease. Now comes the treatment. Treatment, remember, medication is the mainstay and lifestyle changes, but surgery only if medication fails. Then we go to surgery. We give some antibiotics, as we have already discussed, that sometimes the bacteria inside the colonic wall may produce the inflammation. That's why we sometimes give antibiotics, ciprocin, metronidazole. These are the antibiotics that we give. Nowadays, we use rifaximin, the gut selective. I think it should be more important, the gut selective. The gut selective antibiotics. The gut selective antibiotics are more important. Sometimes we give probiotics. Sometimes we give probiotics just to change the bacterial environment of the intestine. Corticosteroids is important in case of acute case. Aminosalicylic acid, sulfasalazine, mesalazine, these are for maintenance. For maintenance. Steroids, remember, in case of acute disease, Steroid is the mainstay of the treatment. Aminosalicylates, these are maintenance of remission. Antibiotics, metronidazole, ciprocin are used. Immunomodulatory agents like azathioprine, very important. If you remember, we cannot continue steroids for a very long time. That's why we use immunomodulators like azathioprine. This you'll get as Imuran. Imuran. You give this. This has a steroid sparing effect, and also maintenance therapy can be used. Nowadays, this is very important, the monoclonal antibody like infliximab, which is not available in Bangladesh, but in case of fistula formation, this has a very, very good role. Nutritional support, the patient may have malnutrition, so nutritional support is another very, very important aspect of the treatment. Endoscopic, now, endoscopic dilatation is another treatment. For example, in case of Crohn's disease, you know, there is always a chance of stricture. So our endoscope can go over here and dilate this part. And dilate this part. So endoscopic dilatation is another way that can be done, but never in acute case, not in acute case. Not in acute case. Surgery. Remember, surgery cannot cure the disease. It's very important. We do surgery only when, in case of acute problems which cannot be cured by medicine. And commonly after the first surgery, there is again, disease may flare up at the site. After resection, there may be a scar tissue formation. So we always do a limited surgery. Always remember, we do a limited surgery. Limited surgery. Never extensive surgery, because you know that this is a disease starting from mouth to anus, so it will never cure the disease. So we try to do a limited surgery and preserve the gastrointestinal system as much as possible. What are the indications of surgery? When we will do surgery? Recurrent intestinal obstruction, severe bleeding, perforation, failure of medical treatment. This is very important. Failure of medical treatment. This is very important. Fulminant colitis, intestinal fistula, malignant changes, and perianal disease. So commonly we do operations in case of perianal disease because these severely deteriorates the quality of life of the patients. And we usually give loose ceton. Now remember that loose, you don't have to remember this, or drainage ceton. Drainage ceton is used. This is quite common. You'll get quite a number of patients given drainage ceton. Maybe another day we will discuss about this. It usually helps the patient. So we commonly use drainage ceton for these patients. Surgery. Don't have to know all of this, but just I will discuss a little bit about this. Ileocecal resection, when the terminal ileum is involved, maybe there may be a stricture over there and there may be recurrent obstruction. You do limited resection. We do not do a total right hemicolectomy. You just remove the ileum and the cecum and then anastomose. You always anastomose the ileum with the ascending colon. That's because we want to preserve the intestine as much as possible. Segmental resection, whichever part is involved, we cut that part. Colectomy with ileorectal anastomosis. Colectomy with ileorectal anastomosis. So, okay. The colectomy and ileorectal anastomosis. When? When there is a colonic disease with rectal sparing. The rectum is spared, but the colon is involved. Then you do a colonic resection with ileorectal anastomosis. Subtotal colectomy with ileostomy. Case of acute colonic disease. Temporary roof ileostomy. This is quite commonly we do in case of severe perianal disease. You see that multiple deep-seated fistula with abscess. You do an ileostomy and usually it has very, very good effect. Proctocolectomy. Coloanal disease not responding to medicine. And stricturoplasty. This is an example of stricturoplasty. If you look at this, you have first resected A and B, resected, and longitudinally we cut it longitudinally and stitch it transversely. This is stricturoplasty. Cut it longitudinally and stitch it transversely. This is how we do stricturoplasty. So prognosis, as we have already discussed, this is a prolonged disease. Medical and surgical care is necessary. Anticipate complications, manage them, avoid side effects of drugs. If you remember steroids, don't give them, although steroid is a very good drug, don't give long-term steroids. But very importantly, few die due to direct effect of the disease, because nowadays the treatment is very, very successful. So if you can treat the patient early, before complications happen, if you can maintain remission for a long time, ultimately the patient has very good chance of surviving this disease and maintaining a normal daily life. So in case of Crohn's disease, it's very important that you do an early diagnosis, prevent complications, maintain remission, and keep the patient under surveillance, because there is always a chance, a rare chance, that this patient may have malignancy in long term. So keep them under surveillance. Thank you for your time.